তোমরা দেখে নেবে কম্পিটেন্সি কি একটা আছে 1.5 না কিরকম একটা আছে যে ট্রান্সপোর্ট অ্যাক্রস দি সেল মেমব্রেন, প্লাজমা মেমব্রেন। এখন সেল মেমব্রেন, that is the discussion not only cell membrane, unit membrane, mitochondrial membrane, nuclear membrane, endoplasmic reticulum, Golgi apparatus, lysosomes, everywhere, paroxysomes, membrane bound organelles, they have the relatively same process. So it is called the transport across the membrane. You know that the membrane, you can remember, it consists of a bilipid layer, and through these interstices of these molecules, phospholipid molecules, primary structure of the cell membrane is by phospholipids. You can remember that when you consider the part of a cell membrane, then you will find this type of structure in your books. Structure of the cell membrane, gross structure, phospholipid molecules. There is the hydrophilic part and it is the intermediate the hydrophobic part. It is the ECF, extracellular fluid, membrane, cell membrane, and ICF, intercellular fluid. These are the polar part, this is the non-polar part. This is disposed in this membrane. Dimension 4 nanometer or so, you can see in the text. Now, the composition of intercellular fluid and extracellular fluid are different. Extracellular fluid is sodium rich. Concentration of sodium in the extracellular fluid, on average it is sodium concentration in the extracellular fluid is around 140 millimole or milli equivalent per liter. 145 millimole or milli equivalent, whatever it may be, per liter. But potassium concentration in the extracellular fluid is low, it is 4 milli equivalent per liter. But in the intercellular fluid, potassium concentration is 150 milli equivalent per liter, and sodium concentration 15 milli equivalent per liter. Chloride concentration is more in the extracellular fluid, 105 milli equivalent per liter, and chloride concentration here is much less, it is around 7 milli equivalent per liter. Chloride concentration. So it is a selective membrane. From these figures, it is apparent there must be some mechanisms to separate these fluids to some extent regarding composition. Proteins are present in the intercellular fluid. Their presence is at much lower concentration. Now the molecules can move. Some molecules can move through this, through this. Suppose water molecule, oxygen, carbon dioxide, nitrogen, and they can move in this way, in between the interstices. Interstices of the space in between these molecules, they can. But the rate is relatively limited, especially in case of water. But the other gases move freely. Suppose in the respiratory membrane, oxygen, we are inhaling air, oxygen present in the, and concentration of oxygen is more in the within the alveoli than in blood within the capillaries that contain this less amount of oxygen, because oxygen is utilized in the body. Partial pressure difference or concentration difference. So oxygen can diffuse through this membrane, and in that case partitions, it is the at least 2 membranes of the endothelial cells and at least 2 membranes of the epithelial cells. In this way, the exchanges. Carbon dioxide concentration more in the pulmonary venous blood capillaries, and they traverse within the alveoli where the oxygen carbon dioxide concentration or partial pressure is low. And these are by the process of diffusion. But the hydrated molecules, so this process has this is the one is the diffusion. Simple diffusion and facilitated diffusion. Facilitated diffusion. Facilitated diffusion. Oxygen transport, carbon dioxide transport, these are the or water transport, these are examples of diffusion. And it follows this concentration gradient, or in some cases the electrical gradient. Positively charged particle or the cations has a tendency to move towards the negatively charged area. Similarly, anions, they are negatively charged, they have a tendency to move to positively charged area. And in this case, it is a physical process. No cellular energy is required. And these are the examples of diffusion. But in some cases, such a slow process is not sufficient, because the molecules that is present in the extracellular fluid, and they are in the hydrated forms. Yeah. Inorganic or organic whatever molecule in hydrated form. Suppose it is the sodium ion and hydration. Potassium ion, it has some hydration cell. So hydrated form are relatively, they are the effective size, and they do not traverse through this interstitium space. So they require some other pathway. When required. Suppose during the development of the action potential, sodium ion have to enter quickly across this membrane into this sensor. And potassium has to leave this, and they are all hydrated forms. And for this reason, quick process is required. So there may be some protein channels. Ion channels or carriers are there. Second, there is the ion channels. And carriers. Carriers are there. Carriers are for this, mainly for the facilitated diffusion, and ion channels to allow the hydrated forms to enter. Ion channels. And they can, and these ion channels, they are formed with the protein units. Every cell membrane, they contains, besides phospholipids, some cholesterol, some sphingolipids, and they also contain protein molecules. And protein molecules are of different types. Some go through and through, or some partial, some are integrated, and some are superficial. Now, whenever they are integrated, they bear this role. They are in the form of subunits. Suppose if you consider this, and if it is a membrane, there may be a subunit that they enter in this way, or they enter, and in this way they are produced, and they are connected to one another in this way, connected to one another in this way. They may be connected to one another in this way. Suppose it is the N terminal and it is the C terminal, and in this way they are connected. The basic understanding, the subunits, they form subunit structures, and subunit structures are formed by these cells according to the requirement, and they form a single unit may carry ions by the structure, conformation. You have read in the biochemistry the formation of the proteins from the amino acids, amino acids, and they are in different types, secondary structures, tertiary structure, quaternary structures. They may form a helix, alpha helical pattern, or beta pleated sheet, or also in some cases in some linear form, according to the requirement in nature devised it. Suppose in case of potassium channel, if you consider potassium channel, it consists of 4 subunits, and each subunit they take part in one subunit in this way. Subunits. They may be similar, or they may be exactly similar, or it may be similar in this way, and they form this. They will take part all in this formation of these pores. Subunits. They are disposed in this way, so that they are forming the pores. If you consider there is the pores, they are forming the pore. They come together to form the pores. 1, 2, 3, 4. In this way, they form. They may be separate peptides in case of potassium channels. Some of the ion channels, they are relatively, that is, non-specific. They are leak channels, LEAK, leak channels. They can allow any ions according to its hydration and atomic weight or molecular weight. They can allow, and there is diffusion in this case. Simple diffusion, leak channels, but some are gated channels. They are particular. Suppose in case of potassium channel, it will not allow other ions to enter. In sodium channels, they will allow only sodium ions. To some extent, they may allow calcium ion in some cases, but it is primarily the sodium ion. There are some calcium channels, and these channels are specific in that sense. They will allow this. Now, potassium channel, when you are considering, suppose it is a voltage gated channel also, and in that 4 subunits, they come together to form these channels. And these subunits are formed by the modification of the unit. It has 6 membrane spanning segment. 6 membrane spanning segment, and between 5 and 6 spans there is a loop, that is the P loop, that forms the pore when they together come in 3-dimensional way. When you consider, suppose if you consider any part, you consider this one, and in that case they are disposed in the membrane in such a way. Suppose it is 1, 2, 3, 4, 5 and 6, and it is this pore. They are disposed in this way. N terminal, C terminal may be inside or outside. You consult the text. I cannot remember everything in detail. Basic concept. The class is about basic concept. I may commit mistake, but this basic concept is the same. Suppose this unit is formed by helices in this way, they are produced. And 1, 2, 3, 4 are disposed in such a way they form a pore in between them. There is this P in this way, so that they form this pore in this way. 3-dimensional. The pore is produced. Or it's in some case, suppose in sodium channel, not only in human beings, but in bacteria also. They have 4 such peptides, but they are not separated. They form 24 peptides, and they have the same P units. Now is sodium 4 in some cases is positively charged. With different color in different texts, positively charged. এবার নিশ্চিত আমাদের জিনিসটা বোধগম্য হয়েছে। এই যে প্রত্যেকটা যে সাব ইউনিট, সেই সাব ইউনিট স্ট্রাকচারটা কীরকমভাবে হলো, এটা হচ্ছে 6টা তোমার সাহায্যে লুপ তৈরি করছে, তার মধ্যে পি লুপ রয়েছে। এই পি লুপটা যেটা সেল মেমব্রেনের মধ্যে রয়েছে, দ্যাট ইজ রেসপন্সিবল ফর ফর্মিং দি পার্ট অফ দি পোর, and the chain 4 in textbooks it is given a positive sign in different color. But in case of sodium channel and calcium channel, they are formed in such a way that they are not separated, they are continuous structures, but they are aggregated in like this. The basic mechanism is the same. They form a pore, they will allow a particular ion to enter, and specificity is due to the arrangement of the amino acids with charges inside, negative charges inside, and they repel the water molecules. Suppose potassium ion, atomic weight 39 and sodium it is 23, but the hydrated part is thicker in case of sodium, and its dimension is 12 nanometer, like water, and like water is also this, but it is 18 nanometer. So through the potassium channel, there are the amino acids, they are disposed in such a way that, and the water molecules, and you all know in higher secondary courses in the chemistry text, and they form partially positive, partially negative form, because the oxygen has a tendency to attract electrons from the sodium, from the hydrogen. So hydrogen will get an imaginary positive charge, and so they are not completely neutral, and for this they form different types of interactions with these water molecules of with the amino acid, charge of the amino acids, and so there is liberation of this, and there is partial or complete liberation of this water molecule. Suppose the hydrated form is reduced or absent when it is going through the pore, and this pore size, suppose it is flax-shaped, and through this potassium ion, dehydrated potassium ion, waters are liberated in this way, so it can pass, and they will accommodate in such a way that it becomes theoretically possible. Energetically, it is a convenient size so that it can enter. Now we consider if it is sodium, and in that case the distance between is more, so it is not favorable in that sense. Everything detail has not been explored. It is difficult to explain, but in this way they have some explanation in some texts. Modification of the dehydrated forms, and then their size is suitable, size and shape is suitable, so can go through these channels, selective transporters. Now it is the case of potassium, and these channels may be leak channels, and some are gated channels, voltage gated channel and ligand gated channels. Ligand, particular molecule when binds with it, it becomes open. You can remember the structure of the neuromuscular junction, skeletal muscle. The neurotransmitter is skeletal muscle. Neurotransmitter ki naam? Acetylcholine. It is the universal acetylcholine, and it is liberated from the nerve endings. When there is action potential, and then due to this opening of the voltage gated calcium channels, calcium do enter into the terminal part, this is the terminal buttons, and in response to this entry of calcium, by relatively complicated way, there is exocytosis of acetylcholine containing granules, and acetylcholine do enter into the space between the Space between these, there is the membrane of nerve and the muscle, neuromuscular junction. And it then diffuse close to the nicotinic receptors and where it can bind. And then this channel is open. It is a typical example of ligand-gated channels. And it is composed of 5 subunits. 5 subunits. And in this way, suppose 5 subunits, they come together to form this. They come together to form this. Suppose there is alpha 1 and it is another alpha 1. It is beta 1, it is gamma, it is delta or epsilon in some cases, and they form this force. And the alpha subunit is primarily responsible for this. It is the transverse section. And you see in the textbook, laterally how they are disposed. When acetylcholine molecules bind with the alpha subunit, then there is opening of the channels. Normally it is closed. Normally the channel is closed. But when calcium binds with, there is the alpha units, and when acetylcholine binds with it, and then there is opening of this. Conformational change, and there is opening, and sodium enters through this. And potassium, then it becomes open for a short time. These are the examples of, this is an typical example of ligand-gated channel. Similarly, there are also other channels, and they form mainly pentamers. And this pentamer, there is the alpha, beta, alpha, gamma, delta or epsilon, and they are also maybe of subtypes for different masses, different area also. Now, these are examples of ligand-gated channels. GA, BA, gamma aminobutyric acid A transporters. Glycine, some glutamate receptor, and they may be ligand-gated channels. Some channels are dimers with the opening in each part. CLC channel, you will find in the text this type of figure. And there is a pore in each subunit. CLC, chloride CLC channels. It is present in many sites. Calcium ion can enter within these pores. These are the pores. But there are other types of chloride channels. Other types of chloride channels. Suppose for the example of the CFTR. CFTR depicts the channel cystic fibrosis. Related to cystic fibrosis. CFTR channel. Cystic fibrosis related calcium chloride channel, CFTR. And they are also called ABC type of transporter. Cassette, in this way they are called. And they are formed of two membrane spanning segment, and their regulatory part and another nucleotide binding part. Not only chloride ion, but also other substances can traverse through this. And in that case, suppose cell membrane spanning M1 and M2 part, and they are connected in such a way that is a regulatory part and a cyclic nucleotide binding. by means of ATP. ATP is there. ATP, they also allow chloride ion to enter. When ATP is bound with it, detail I cannot remember. This is another type of chloride channel. ATP binding cassette proteins, ABC protein they are called. Not only chloride ion, but also other elements can pass through this. Now these are the type channels. Water can enter through this water. But whenever there is requirement of quick entry of water, and then these channels are relatively slow, and there are formation of aquaporins. They formed of 4 subunits, and each subunit has the capacity of transporting water. Aquaporins. There are different types of aquaporins. In the renal tubules, they are. Elsewhere, there are aquaporins. 1, 2, 3, 4. They all come together to form a sporocyte that can transfer ions, but and they have the pores within this. This through the water can easily enter. Water movement is always passive, and principal force is a diffusion or osmosis in this case. Suppose in the collecting tubule or collecting duct, there are the cells, it's called P cells also, and whenever there is osmotic difference, water will move from inside to the outside, aquaporins, quickly, and it is possible. And it may remain within the cells, along with the vesicles. Suppose whenever there is dehydration, and there is liberation of vasopressin or antidiuretic hormone from the posterior pituitary, and they will have their action over the basal part of the renal tubular cells, so the distal nephron, and there is generation of cyclic AMP as second messenger, and in response to this, there are some mechanism by which the vesicles are inserted into the membrane, then the membrane bears this aquaporins, and through this water can easily pass, and the concentration of water within the tubule will increase, and it may go up to 1400 milliosmol per liter. Normally, extracellular fluid or plasma has a osmolarity of approximately 300 milliosmol per liter. But whenever there is severe dehydration, it is possible to attain this concentration of the urine, highly concentrated urine, and in that case 1400 milliosmol per liter it is possible. And it is due to these aquaporins. Not only in the distal nephron, elsewhere they are also present, aquaporins. Yeah. And 4 subunit, this is central pore, they may carry some ions. Now the movements of ions, you can then, that is some are carrier mediated, and it is we are discussing the process of diffusion, but there is active transport in some cases. Many cases. Active transport is required for which purpose? Suppose there is requirement, that is this against the concentration gradient or against the electrical gradient, and in that case, there must be, it is an uphill process, and in that case it is required. Suppose sodium concentration in the extracellular fluid is 145 and intercellular fluid is 50. So transport of sodium is natural from extracellular fluid to intercellular fluid through leak channels also. And the permeability is different for different ions. Potassium is relatively highly permeable highly permeable in comparison to sodium. Sodium cannot enter through the cell membrane because it is larger size, larger hydrated form, it cannot enter. But in some cases it is required for sodium to go from inside to the outside, inside to the outside, and in that active transport, and they have enzymic activity, because whenever there is uphill, then there is requirement of ATP. ATP is broken down into ADP and inorganic phosphate, and then this ATP is responsible for the movement. Similarly, potassium ion is more in the intercellular fluid. So, tendency of potassium is go to outside, and it requires energy, cellular energy, to push potassium from outside to inside. And it is required to maintain the membrane potential, and active transport is there. Suppose within the stomach, the pH is around, normally it is acidic, 1 to 2 pH, 1.0, 2.0 or so, and in the extracellular fluid or within the cells itself, it is 7.2. So, there must be some activity, cellular activity, otherwise how it is possible? How it is possible? You are learning GI system. Hydrochloric acid is secreted from which cell? Which cell is responsible? Peptic cells? No, it is not peptic cells. It is parietal cells. Peptic cells are there, and they secrete pepsinogen. Pepsinogen is converted by acid chloride down into its active form, pepsin. And this pepsin is then breaks down other pepsinogen molecules to pepsin, and in this way this occurs. That is called chief cells. It is called chief cells or peptic cells, but this it is oxyntic cell or parietal cells. And they, whenever they are not secreting acid, then their microvillar structures are not prominent, but whenever they are secreting acids, the microvilli become prominent. Within the cells there are some vesicles, and they then unite with this canaliculi to increase the surface area. And here there is hydrogen potassium hydrogen active transport, because whenever their secretion begins, hydrogen concentration within the lumen increases, and so from the cell where the pH is much more, it will enter into this lumen against this potassium from the low concentration to high concentration. Suppose whenever there is occurs, suppose it is the parietal cell, at the surrounding part there is this, and in that case there are, and whenever it is secreting, then there is this canaliculi, they will unite with this. And suppose in this part hydrogen potassium, it is hydrogen ion is coming from this, that is cytosol, within this lumen hydrogen ion, and potassium ion are lower concentration, and potassium ion is coming in this way, potassium ion from this potassium ion. And so HCl concentration increases, and it will come through this, and they are secreted in such a way that they form an ejectile form. They are secreted, crossing to this membrane layer, ejectile form. So they do not relatively disturb this. It is come into the lumen, and this mucus protects the gastric mucosa, so that there is no damage to the mucosa. বোঝা গেল? ওটা যখন বেরোয় পুচকিরির মতো বেরোয়, এবং যেই মিউকাস দিয়ে ওটা ঢাকা থাকে, সেই মিউকাসের ভিতরে নানা রকম বাফার আছে, কাজেই সেটাই খুব বেশি ডিস্টার্ব করে না। একবার যখন লুমেনে চলে এলো, খাদ্যের সঙ্গে যেগুলো আছে তার সঙ্গেই রিয়াকশন হচ্ছে, কাজে মেমব্রেনের যে মেমব্রেনের অ্যাসোসিয়েটেড যেইগুলো রয়েছে, যে মিউকাস রয়েছে, তার খুব একটা বেশি পিএইচ কমছে না। এটা নেচার্স ডিভাইস। তার ফলে তারা প্রোটেক্টেড থাকছে, অ্যাসিডের দ্বারা তাদের কিছু ক্ষতি হচ্ছে না। রেস্টিং কেসে ক্যানালিকুলিগুলো ভিতরে রয়েছে, যখন অ্যাক্টিভ হলো তখন যেমন দেখিয়েছি, সেগুলো এসে যুক্ত হয়ে সেটা চ্যানেল তৈরি করলো, এবং সেখানে অ্যাসিডটা যখন তৈরি হলো সে একটা হাইড্রোস্ট্যাটিক প্রেশার একটা তৈরি করছে, যেমন পিচকিরি মতো সেটা বেরোচ্ছে, যেটা ওই মিউকাসটাকে ক্ষতি করছে না। এভাবে নেচার তৈরি করেছে, সহজে এর জন্য আলসার হচ্ছে না। খুব বেশি অত্যাচার না করলে সাধারণ লোকের খুব একটা আলসার হওয়ার সম্ভাবনা কম। তাও পেপটিক আলসার অনেক সময় হয়ে যায়। অ্যাসিড পেপটিক ডাইজেশন, এই মিউকাসটাই প্রোটেকশন দেয় মূলত। ওখানে কতগুলো পেপটাইড আছে যারা বাফার হিসাবে কাজ করে, দেখবি বইয়ে দেওয়া আছে ট্রিফয়েল পেপটাইড, তাদের ইয়েও দেওয়া আছে, স্ট্রাকচারও মোটামুটি ছবিতে দেওয়া আছে, সেটা কাজ করে, বাফার হিসাবে কাজ করে, চট করে সেটা হয় না। পিএইচটা এর জন্য সেল মেমব্রেনের কাছাকাছি পিএইচ অনেক বেশি থাকে, লুমেনেই কম থাকে। এই জন্য ওখান থেকে অ্যাসিড বেরোচ্ছে, কিন্তু স্টমাকের কোনো ক্ষতি হচ্ছে না। লক্ষ লক্ষ লোক, কোটি কোটি লোক ঘুরে বেড়াচ্ছে, স্টমাকের আলসারে আর পেপটিক আলসারে কটা লোক আর ভুগছে। এই যে সুস্বাদু খাদ্যটাতে সব লোক খাচ্ছে, হ্যাঁ, তাতে অ্যাসিড প্রচুর বেরোচ্ছে না, হ্যাঁ, সেটা লুমেনে গিয়ে পড়ছে। নেচার প্রোটেকশন দিচ্ছে উইদিন লিমিট। যারা এর জন্য জীবনযাপন করে খাদ্যটাতে সব ব্যাপারে, তাদের রোগ খুব কম হয়, খুব হতে চায় না। বুঝতে পেরেছো তো? এর জন্য এখন সহজেই ভাবে যে লোকটা শত্রু, আমার মরে যাবে, চট করে মরতে পারে না। নানা রকমের প্রোটেকশন আছে, এর জন্য মাঝে মাঝে খুন খারাপি করার দরকার হয়ে পড়ে, যে লোকে করে ফেলে সেগুলো। এভাবে স্টমাকে প্রোটেকশন দেবে, এটা পরীক্ষায় দেওয়া হয়। এটা পরীক্ষায় তোমাদের যে সিস্টেমের, এটা তোমার ওরালও জিজ্ঞাসা করা হয়, প্র্যাকটিক্যাল থিওরি প্রশ্ন দেওয়া হয়। প্রোটেক্টিভ ফাংশন অফ দি গ্যাস্ট্রিক মিউকোসা, এটা দেখবে, এটা তোমাদের টেক্সট বইগুলোতে ভালোভাবেই দেওয়া আছে, মানে যে ফ্রেন্ডলি টেক্সট, যে স্টুডেন্ট ফ্রেন্ডলি টেক্সটগুলোতে ভালোভাবে দেওয়া আছে। মানে আমি একটা সিস্টেম থেকে অন্য সিস্টেম অটোমেটিক্যালি, এটা একই তো সাবজেক্টের জন্য এটা এরকম হয়ে যায়। Now sodium potassium ATPase, it is very much important. Primary active transport, it is very important. Sodium potassium ATPase, it is important for the কিছু কিছু জিনিস মুখস্থ করতে হয়। সোডিয়াম পটাশিয়াম ATPase তোমরা যে যাই বই পড়ছো সেটা থেকে মুখস্থ করে নিতে হবে, কীভাবে স্ট্রাকচারটা আছে বা আছে। ডিটেইল জানতে গেলে পরে তোমার জ্ঞান অনেকটা আছে, বোরনে আরও ডিটেইল দেওয়া আছে, বায়োকেমিস্ট্রি টেক্সটও আলোচনা করা আছে। কিন্তু সাধারণ ক্ষেত্রে তোমার যে টেক্সট বই আছে, তুমি যার টেক্সট বই পড়ো না কেন, ও মোটামুটি এটা দেওয়া আছে, সোডিয়াম পটাশিয়াম ATPase, ইট ইজ ইম্পর্টেন্ট। Sodium potassium ATPase, when you consider it, two subunits. There are also other part written in the text. There are membrane, cell membrane. Suppose it is the beta unit, and it is the alpha unit. They describe in this way. It is alpha unit. Other subunits are there. If you go to boron or say, there are less important subunits, but they are principally alpha and beta subunit. And the alpha subunit is responsible for the transfer of sodium and potassium. এগুলো খুব সহজ মুখস্থ বিদ্যা, তাও আমার যতটুকু জ্ঞান বুদ্ধি আছে বলে দিচ্ছি, তারপর তোমার বই থেকে পড়ে নেবে। 3 sodium ion, it has different sites. 3 sodium ions unite with this sodium binding sites. And they are all ATPases, and there is ATP binding site. Suppose it is the ATP binding site, and it is the phosphorylation site. 356 গুলি যাচ্ছে, 350 অ্যামাইনো অ্যাসিড দরকার নেই, এটা হচ্ছে phosphorylation site, where there is the inorganic phosphate binds. ADP divides into ADP plus PI, this pi here, inside. It is the outside ECF. It is the ICF. And it is the ubiquitous. It is present in all the cells, almost all the cells. Almost all the cells, they bear sodium potassium ATPase. And whenever ATP sodium binds, then ATP sodium potassium activated ATPase, sodium potassium ATPase it is called. And when sodium 3 sodium ion unite with this sodium binding site, and it is the ATP binding site, and it is broken down into Pi and ADP, and there is some conformational change, and at the same time then it is the potassium binding site, 2 potassium ion binding site, and it is the uabin binding site. Digital is OUABAIN, uabin binding sites, and there is conformational change, and sodium is pulled to outside, and potassium is, and this phosphorus that unites, they will come out. So it depends upon this, it is not saturating in this case. So whenever there is increase in the sodium ion inside, and 3 sodium ion binds with it, and when this, then ATP also binds, and it undergoes this ATPase activity. This alpha unit is the responsible for this transfer, but its union with the beta unit is required. Without this beta unit, it cannot work. And in that case, the beta unit, it has 3 glycosylation sites. There is the glucose moieties are used, and their molecular weight is 55,000, and it is 100,000. Transfer occurs through the alpha chain, but association with the beta chain is required, somehow required to have this process done. So when 3 sodium ion unites with it, then the ATP undergoes broken down by the subunit, ATPase activity, into Pi plus ADP plus energy, and it is the phosphorylation site. And in that case, a conformational change, and from the outside, and the sodium is eliminated, and potassium at the same time unites, and it will bring to this site. So 3 sodium ion, ultimately the result is the 3 sodium ion come out, and 2 potassium ion will enter. So it is electrogenic also. 3:2 ratio, 3 sodium, 3 positive charge versus 2 positive charge. So there is some excess positive charge in this case. So it is to some extent, it is responsible for the membrane potential. Membrane potential we will discuss on other day, and it is due to mainly the diffusion potential of the potassium ion. But it is maintained by the sodium potassium ATPase. বোঝা গেল? এগুলো খুব সহজ জিনিস, এগুলো এইসব ফিজিওলজি ক্লাস, বুঝতে পেরেছো? বইয়ে সমস্ত লেখা আছে। এই যেমন ধরুন অনেকেই আসে না, আগে যখন চাকরি করছি সেখানে অনেকে আসতো না, কারণ বইয়ে সব লেখা আছে, পড়লেই বোঝা যায়। হ্যাঁ, সেই কালক্রমে হয়তো সব সাবজেক্ট উঠেই যাবে, বলছে না এত মেধাবী লোক হয়ে গেছে যে এই সমস্ত স্থূল জিনিস আর দরকার নেই। হ্যাঁ, এরা তো পড়েই বুঝতে পারে, আদের এইসব ডিপার্টমেন্টে রেখে এত পয়সা খরচা করে কী দরকার, শুধু পরীক্ষা দেবে তারা। হ্যাঁ, প্র্যাকটিক্যাল উঠে যাবে, হ্যাঁ, শুধু পরীক্ষা দেবে, থিওরি পরীক্ষা থাকবে, কালক্রমে তাই হবে। কারণ মানুষের মস্তিষ্কর হচ্ছে, উন্নয়ন হচ্ছে সবসময়, এই জন্য এটা আমার ধারণা। আর কি এখন জানি না কী হবে না হবে, হ্যাঁ, আমি অন্তত যে কদিন আছি সে কদিন হওয়ার সম্ভাবনা কম, কারণ এটা ইউনিফর্মলি ইট ইজ প্রেজেন্ট। So it maintains. It is partially responsible for the generation of membrane potential, but its requirement is to maintain the membrane potential. Normally, from these values it is apparent that by the leak channels, sodium ion will enter inside the cell, and potassium ion will have a tendency to go outside the cell. So with time, if there is no activity of any pump system, then there is ionic equilibrium, but it is not so. living cell must have a membrane potential. Its magnitude is more in case of excitable tissue. Excitable tissue means that is the nerves and muscle cells, and in that case it is a negative value. Negative means that inside is comparison to outside. It is always mentioned membrane potential, it is inside in comparison to outside. Suppose in an action, if you consider on either side, it is an action, it is positive outside, inside is negative. And by means of cathode oscilloscope or so, sensitive galvanometer, it can be there is minus 70 millivolt. It is expressed as minus 70 millivolt. But during action potential, it may be plus 30 millivolt. So it indicates that inside becomes positive transiently during action potential. It is expressed in this way, inside in comparison to the outside. It is minus 70 millivolt in an average action, and in skeletal muscle it is minus 90 millivolt. In case of RBC, it is minus 9 millivolt only, non-excitable cells. But every living cell has a membrane potential. And sodium potassium ATPase is responsible for maintaining it. Yeah. Due to leak channels or other channels, now there is Donan effect, and due to this, that we will discuss the other day, then there is entry of some ions within the cells. So there is a tendency, and in the plant cells they have a rigid coat, cell coat, but within the vertebrates it is not. It is a plasma membrane. So there is if there is more osmotically active particle within the cell due to Donan equilibrium or so, and water will enter following the osmotic equilibrium, and the cell will gradually enlarge and enlarge. Ultimately it may burst, or it may be non-functional, but it is protected by sodium potassium ATPase. Not only ion, it is also the osmotically active particles. They are pushing out. It is one of the reasons so that this volume of the cell remains constant. Volume of the cell remains constant. Not only membrane deformation. And its activity is suppressed by digitalis glycosides, like we have in digoxin also, digitalis glycosides. And it is used as a cardiotonic drug, increases the force of contraction. In heart failure, it is used, digoxin, or similar type of drugs are used that inhibit the sodium potassium ATPase. And how they are doing this is a subject of pharmacology. Probably it has some role. There is this phosphorylation site, prevents phosphorylation or whatever. I request you to go through pharmacology text. That is, it is inhibited by digitalis glycosides. When the activity of this sodium potassium ATPase is inhibited, then there is the force of contraction of the muscle increases. It is increase in the calcium concentration. Calcium concentration. Suppose in the membrane there is a channel. There is a channel through which the calcium ion is normally calcium ion is higher in this extracellular fluid than this. So calcium ion do enter and exchange of sodium ion. Sodium ion will enter and calcium ion will come out, and there is the exchange mechanism in this exchange mechanism normally. sodium ion will come to outside. Now, sodium ion will go into inside in exchange of calcium ion. In spite of this, calcium ion concentration is low in the cytosol. Now, whenever there is this activity of the sodium potassium activity, ATPase activity is low, then sodium concentration within the cells will be low. So, the exchange of calcium is also low. So, calcium ion concentration within the cytosol will increase, and calcium is primarily responsible for contraction of all the muscles, including the cardiac muscle. So, force of positive inotropic effect, that is the force of contraction of the cardiac muscle can increase, and it is used left ventricular failure or whenever there is the stroke volume or ejection fraction is low. In some cases it is used and it is beneficial. It is given in low doses, appropriate doses. It has some toxic effects also, but it is used. Still now it is used. So, sodium potassium activity is given in their examination. Inhibition of sodium potassium explain. Inhibition of sodium potassium ATPase leads to increased contractile activity of the heart muscle, cardiac muscle. Explain. Then you explain in this way. Explain in this way. There is some exchange. It is not active process, but it is relatively it is the passive process. By means of carrier protein, it is possible that sodium is going from outside to inside, and then calcium is going against this from inside to outside. Now, this pump is responsible for bringing sodium ion outside. So, tendency of sodium to increases, but if this channel, if this potassium activity is blocked, so sodium concentration will go on increasing. So, this tendency of entry of sodium is reduced. So, calcium ion cannot easily go through. So, they will accumulate and within the cell, and they will increase the activity. And you know the calcium concentration, they have powerful effect, very sensitive to calcium ion. In the resting skeletal muscle, the concentration is 10 to the power minus 7 mole per liter, and when it is more than 10 to the power minus 6, and then contraction begins. It is very sensitive. So, that slight change in the calcium concentration is effective in that case. Now, it is the primary active transport. There is the another term, that is the secondary active transport. Secondary active transport, and it is also important. That is the sodium potassium ATPase, calcium ATPase, even hydrogen ATPases in different sites in the lysosomal membrane. That is the within the lysosomes, hydrogen ions is high concentration, and its membrane contain hydrogen ATPases we discussed. Now, there are the examples of primary active transport. Primary, there are some other cases where what uses this sodium gradient to carry another molecule, and it is called secondary active transport. Secondary active transport. It may be within the cells, from outside to within, or from within to outside. It is called secondary active transport. Suppose in case of and in that case, they are disposed in such a way. Suppose the tight junctions, these are the tight junctions, and due to it has a polarity. In some cases, it may be in this way. Suppose in proximal tubule, it is brush border, macrophilar border, and in that case, there is a carrier that brings glucose and amino acids and glucose through this, and it will bind with sodium ion sodium ion. And when this glucose and they will enter from this side by this carrier. It is an example of facilitated diffusion. And in the basolateral side is the sodium potassium ATPase. It brings a sodium potassium ATPase. So the concentration of sodium is maintained low, and there is also favoring electrical gradient. Suppose the minus 50 millivolt membrane and inside negative. At the same time, concentration is 10 times in outside luminal side this. So sodium will enter, and it will bring a glucose in this glucose. And glucose then exit by the transporter called GLUT, GLUT, GLUT2. So it is an example of secondary active transport. Because the cell maintains the polarity. The proteins that are embedded in the luminal side, they cannot traverse to this tight junction to the basal side. Similarly, sodium potassium ATPase, they are inserted in the basolateral side. It cannot go in this way. Polarity is maintained. On the other hand, and in that case, you can call it, and it is called SGLT. Sodium dependent glucose transporter, 1 and 2 there. 1 and 2. Suppose 1 glucose or 2 glucose or in this way, whatever may be. The basic concept is that. On the other hand, there may be exchange. Secretion of hydrogen ion is possible by this exchange mechanism. There are different types of GLUTs, GLUT, and there are 12 membrane spanning domains, and they are good examples of facilitated diffusion. Normally, all the cells, most of the cells, like adipose tissue, skeletal muscle, heart muscle, and other cells, most other cells, that are insulin dependent. And in this way, there is the glucose transporter, GLUT4. By means of insulin, this GLUT4 remains within the vesicle normally, but when insulin binds with the receptor, then there is some change, biochemical change, and this membrane carrying this glucose transporter inserted into the membrane, so that glucose can enter by the process of diffusion. These are the examples of facilitated diffusion. And GLUT, suppose a GLUT1, and it is the example of an uniport. It will allow one particular molecule. But in some cases, it is co-transporter, and this is an example of co-transporter, salt glucose, or counter transporter. And how it? Suppose within the cells, H2CO3 is formed by carbon dioxide. It breaks down into hydrogen ions and HC3 anions. And this hydrogen ion will come through against the sodium ion that enters by means of a channel. It is an antiport mechanism. In this way, hydrogen ion will come out. And it is also a secondary active transport, because the principal energy is coming through this, that is this low sodium ion concentration maintained by the active transport of sodium, and the sodium potassium ATPase activity is lowered by any drug. Then not only sodium, but the entry of this and salt glucose, that is this transport, and for this reason, that is this oral, there is the electrolyte that is taken in whenever there is diarrhea, vomiting, cholera also, and so glucose is given along with that is this, they contain sufficient glucose and also sodium, and in that case this channel is not blocked by any disease. So they will allow sodium to enter along with glucose, and it is highly protective. electrolyte, replacement therapy, and it has saved millions of lives and saving millions of lives. And common man also know that whenever there is fluid loss, then they mix at least within the room, any house you will find common salt and sugar, and they mix it and give the patient along with water, and there is good replenishment. And the SGLT is responsible for this. It is clinical importance in that sense. So these are these. In some cases, there are whenever there is entry of the protein molecules are required, larger molecules. The hydrated forms can be tackled by these protein subunits, but whenever there is larger molecules that require entry or exit, then these mechanisms will not operate, and then the cell then act together. Exocytosis and endocytosis. That is also a means of transport of substances across the membrane. Exocytosis and endocytosis. Suppose within the saliva there is the ptyalin, how it is, from which source it is coming? From the acinar glands of the salivary glands. They are coming. The hormones are coming out by the process of exocytosis. Acetylcholine is coming from neuromuscular junction from the neuron exocytosis. Similarly, endocytosis is there, and you are familiar with the terms phagocytosis, pinocytosis. They are all active process. They require ATP, GTP, or in this way. Docking of these vesicles in between, that is within these cells, and that is an interesting part. But time will not permit, so we stop in this. You have to read. আমি যেটা বললাম অনেকটা অসম্পূর্ণ এবং কোনো জায়গায় ত্রুটিপূর্ণ হতে পারে, তোমরা নিজেদের জ্ঞান বুদ্ধি দিয়ে সেটা করে নেবে, ঠিক করে নেবে। ঠিক আছে, আজকের মতো শেষ।
If a sample positive result for blood sugar and protein also, that's mean a symptoms glycosuria and proteinuria, both the symptoms comes in the same sample, and the subject is diabetic nephropathy. Okay, if there is blood sugar positive with ketone bodies, you know? Yes, very good. It is patient of DK. We call diabetic ketoacidosis. Either it is not that these both the things are comes combinedly in a same urine sample. Okay, in a same urine sample, if this sample get positive result for blood sugar and also for ketone bodies, then it is like that. Understand? Same for bile salt and bile pigment. Both the things are come. Then it is jaundice. Majorly which kind of jaundice? Jaundice is not simply. You just say jaundice. हाँ? वही आदत है तुम्हारी, सोचना नहीं है, बोलना है. But it is obstructive jaundice. Sorry. Obstructive jaundice. Okay. So this is assumed that if both the sample positive in such cases, the sample may be from such patients. Okay. And you already know that proteins and your blood sugar represented by this way: tetra positive, double positive. Okay, that's mean this shows some of the concentration in the urine sample. Okay, so question is comes just like that. Report the urine analysis. Whenever you perform this test in a unknown sample, then if you will get result for these constituents, then you will write in the result that this sample may be from a person who has suffered from diabetes, ketoacidosis, or either obstructive jaundice, if both the results come in a same subject. And same questions also comes and you already complete here Benedict test and heat coagulation test. Okay. And today you are going to discuss about Ruthras test. Ruthras test, Hay-Sulfur test and Faucett test. They are the three tests, and one of the important test is called Benzidine test. Benzidine test for hematuria, but it is now a condition banned in the laboratory because Benzidine is carcinogen. That's why it is not used in the laboratory. It is banned. Okay. So you are here perform only three tests: the Ruthras test, next three tests: Ruthras, Hay-Sulfur for bile salts, and lastly you will perform about last one, Ruthras Faucett test. Okay, these are last three tests which you will perform. Ruthras test for ketone bodies. There are majorly three ketone bodies you already know: acetate, acetone, and beta hydroxybutyrate. These ketone bodies are generally comes from by the metabolic pathway, by the beta oxidation of fatty acids.
Cardiac glycosides. What do we mean by glycosides? Anyone from that row? What do we mean by glycosides? Basically, it's a chemical molecule where one molecule of sugar is combined with a non-sugar molecule by a bond called glycosidic linkage. So, when the glycosides have got the property or clinical benefit on the heart, they are called cardiac glycosides. They have got inotropic property. Basically, they increases the myocardial contractility. Now, among the cardiac glycosides available, there are digoxin, cardiac glycosides. What are the available drugs? Anyone from this row? Ball. Cardiac glycosides ki available ache re? What are the drugs are there? Huh? Jore bol. Digoxin. Digoxin is the only cardiac glycoside that is currently in medical use. Other than that, the other cardiac glycosides are anyone? Sorry? তোমাদের ক্লাস তো হয়েছে, পরীক্ষা হয়েছে। আর digitoxin and ouabain. Now, cardiac glycosides, the primary source are plants. They can also be obtained from the toad skin. The digoxin, which is the only drug currently in clinical use, are obtained from that row. The source of digoxin. Anyone? জারিয়ে বল একজন কেউ বল, ঠিক আছে বল না, ভুল হবে কি হবে? Digitalis purpura is basically the source for digitoxin, and for digoxin it is Digitalis lanata. Okay. Now, they are found in several plants and in the toad skin. Digoxin is the only cardiac glycoside currently in use, source being Digitalis lanata, already written there. Now, the pharmacological action. Anyone? Pharmacological action from this row. Pharmacological action of digoxin. Anyone? কি কাজ করে ডিগক্সিনটা? হ্যাঁ, সরি জোরে বল। Very important, already discussed. It has got inotropic property, so it increases the myocardial contractility. Right? Now the second question is, how does it increase? তো যখনই জিজ্ঞাসা করবো কি মায়োকার্ডিয়াল কন্ট্রাক্টিলিটি কীভাবে বাড়াচ্ছে, মানে মেকানিজম অফ অ্যাকশন কে বলতে পারবে? হাউ ডাজ ডিগক্সিন অ্যাক্ট? Mechanism of action of digitalis or digoxin in heart failure. খুব কমন কোয়েশ্চেন তো পরীক্ষাতে। সরি, জোরে বল না, জোরে বল। আচ্ছা, ওকে ওকে বল। এটা কি বই খোলা ক্লাস রয়েছে? বইটা বন্ধ কর, বাড়িতে গিয়ে পড়বি। বল, হ্যাঁ কি বলছিস বল। সোডিয়াম পটাশিয়াম এটিপিএস পাম্প, ঠিক আছে, এগুলো পড়তে হবে রে, পরীক্ষার সামনে চলে আসছে। হ্যাঁ, তো সোডিয়াম, হ্যাঁ সরি বল, হ্যাঁ, তো সোডিয়াম পটাশিয়াম এটিপিএস পাম্পকে ইনহিবিট করে। দেখ, is a schematic diagram showing the mechanism of action of digoxin. Here digoxin is binding, সবাই দেখতে পাচ্ছিস রে? Here digoxin is binding to the sodium potassium ATPase pump from the extracellular phase. This is the cell membrane, is the cytosol, and is the extracellular phase. So digoxin is binding at the extracellular phase of the sodium potassium ATPase pump. What the sodium potassium ATPase pump do? It causes efflux of the sodium. 3 molecule of sodium is effluxed against the influx of the 2 molecule of potassium. Now what happens when this sodium potassium ATPase pump is inhibited? The sodium efflux does not occur, so the cytosolic sodium increases. Now there is a second channel nearby, you see, sodium calcium exchanger. What does it do? It causes the opposite thing, it causes the influx of the sodium against calcium, two molecule against the calcium. Now when the cytosolic sodium is increased because of the inhibition of sodium potassium ATPase pump, what happens? Due to increased concentration of sodium in the cytosol, the influx of sodium no longer occurs from the sodium calcium exchanger. As a result, calcium is not effluxed, so the cytosolic calcium concentration is increased. বোঝা গেছে? Right? So ultimately the cytosolic calcium concentration is increasing, and that is stored in the endoplasmic reticulum by sarcoplasmic endoreticulum calcium ATPase2. That causes the entry of calcium from the cytosol into the sarcoplasmic reticulum. Now when the contraction occurs, this calcium is released by the ryanodine receptor 2 calcium activated calcium channel, and there is influx of calcium during contraction from the L type calcium channel, and that is causing, due to increased concentration of calcium, the contraction is facilitated. বোঝা গেছে? Basically due to the inhibition of sodium potassium ATPase pump, the cytosolic sodium concentration is increased. As a result, the sodium calcium exchanger does not work, and the cytosolic calcium concentration is increased as it is no longer effluxed, and this increased cytosolic calcium concentration, that is helping, facilitating contraction of the myocardium. কাজ করছে না রে? So প্রথম অ্যাকশনটা হলো it increases the myocardial contractility, pharmacological action. So due to the increase of myocardial contractility, the systole is shortened and the diastole is prolonged, and that basically helps the failing heart to pump more amount of blood. Now second action is on the electrophysiological properties of the heart. এই যে অ্যাকশন সোডিয়াম পটাশিয়াম ATPase পাম্প উপর অ্যাকশন হলো, তার अगेंस्ट ইলেকট্রোফিজিওলজিক্যাল প্রপার্টিজ অফ হার্টের উপরে কি অ্যাকশন হবে, কি বলতে পারবে? The blue one is basically the untreated myocardial fiber showing the normal action potential, and the red graph is basically the action potential of the digoxin treated myocardial fiber. Now what we can see is this is we know phase 0, this is the phase 1, this is the phase 2, phase 3, phase 0, this is phase resting membrane potential, this is phase 0, this is phase 1, phase 2, phase 3, phase 4. Now this one is resting membrane potential. Starting from the resting membrane potential, you see the digoxin treated myocardial fiber, there the resting membrane potential is lesser negative. This is the first effect, right? The second thing is the rate of phase 0 depolarization, that is decreased in digoxin treated myocardial fiber, and the effect is more pronounced in the AV node and the bundle of His. It's for that reason the heart rate decreases, okay, because lesser impulse is being transmitted from the atria to the ventricle. The third one is basically the action potential duration is decreased, and it is more pronounced in the phase 2. You can see the phase 2 here and the phase 2 there. The amplitude of the action potential is decreased in the basically digoxin treated myocardial fiber, and then the rate of phase 4 depolarization, phase 4 repolarization, basically you see the slope is increased here, and that increases the incidence of automaticity. So what now coming to the blood vessels, no prominent basically pharmacological actions, it decreases the pulse rate in congestive heart failure patient. Why? Because the failing heart, when the digoxin is increasing the myocardial contractility, the pumping of the blood increases. So basically increase in circulatory volume, that decreases the sympathetic outflow, and that is causing decrease in heart rate. Again the direct action of digoxin on the AV node, that is decreasing the heart rate. No prominent effect on blood pressure on the coronary circulation. Now kidney, in congestive heart failure patient they cause diuresis. Why? Because of increase in circulatory volume, the renal flow increases, and that is causing diuresis. But in the normal patient, the patient which are not which are not having heart failure, in normal patient or in patient due to other causes of edema, due to other causes of congestive symptom, basically digoxin does not cause diuresis. Central nervous system, little apparent effect in therapeutic dose, but at higher dose it can act on the chemoreceptor trigger zone, causing nausea, vomiting, and in higher doses it can cause basically psychosis and others. Pharmacokinetics, basically digoxin, food delays the absorption of digoxin. Digoxin is highly tissue protein bound, it extensively bound to the heart, to the liver, to the kidney, and then as a result the volume of distribution is very large, 6 to 8 liter per kg. Bioavailability differs among different medicines of among different brands. একটা ব্র্যান্ডের ডিগক্সিনের অ্যাভেলেবিলিটি অন্য ব্র্যান্ড থেকে ডিফারেন্ট থাকতে পারে, ইটস ভেরি ইম্পর্টেন্ট। So, the person who are getting a particular brand, try to stick with that brand. They are primarily exchanged by the kidney, excreted by the kidney. Half life is prolonged in case of elderly subjects and in case of renal failure patients. So, the dose has to be decreased in those patients, the patient, elderly patient and in renal failure, and the full therapeutic effect are attained after 6 to 7 days. Why? Half life is very large, 40 hours. So, getting the steady state concentration, it takes 4 to 5 half lives. So, 6 to 7 days it takes for the full therapeutic effect. What are the adverse effects of digoxin? So, we can divide the adverse effect of digoxin extracardiac and the cardiac. Extracardiac, generally to begin with, the adverse effect of digoxin, extracardiac side effect occurs. So, what are the extracardiac side effects? Nausea, vomiting, আর কি হতে পারে? Gynecomastia is very rare. Definitely serious side effect. Gynecomastia, skin rashes, nausea, vomiting, diarrhea may occur. Acha, what are the cardiac side effects? ওখান থেকে বল, what are the cardiac side effects of the digoxin? এখান দিয়ে any type of arrhythmia may occur with digoxin, starting from the supraventricular and ventricular. ठीक है, any type of atrioventricular block may occur. Hypokalemia, in chronic digoxin therapy, hypokalemia may occur. So, cardiac pulses bigeminus is the common arrhythmia with digoxin, but any type of arrhythmia may occur like nodal or ventricular extrasystole, ventricular tachycardia, ventricular fibrillation. Atrial flutter, atrial fibrillation has also been seen with digoxin therapy, although rare. Now, extracardiac, anorexia, nausea, vomiting, these are the most common side effects of digoxin therapy. Abdominal pain, diarrhea may occur, malaise, headache, mental confusion, disorientation, psychosis, visual disturbance. Gynecomastia and skin rashes are rare. Now, precaution and contraindications. Hypokalemia. Hypokalemia তে কি হবে? Hypokalemia increases digoxin toxicity. ঠিক আছে? Number 2, elderly renal or severe hepatic disease. তাতে কি হবে? We know, already discussed in the pharmacokinetic, that in the elderly subject, renal failure patient, the half life is prolonged. So, digoxin toxicity will occur. Thyrotoxicosis. Thyrotoxicosis already are prone to cause arrhythmia, and digoxin therapy also is a very narrow therapeutic range of drug. So, it is prone to cause arrhythmia. So, arrhythmia may be, there is more chance of precipitation of arrhythmia. And ventricular tachycardia patient, definitely not to be given, because it may turn the patient to ventricular fibrillation. Partial AV block, the patient may turn up to complete heart block. So, not to be given. It increases the effective refractory period of AV node. Wolff-Parkinson-White syndrome, not to be given. Drug interaction, diuretics সঙ্গে কি হবে? Diuretics with digoxin, এগুলো পড়তে হবে। কিভাবে বাড়াবে? টক্সিসিটি বাড়াবে। কিভাবে বাড়াতে পারে? একটু আগে ডিসকাস করলাম হাইপোক্যালেমিয়া। ডায়োটিক কি করে? হাইপোক্যালেমিয়া করে। নেক্সট ক্যালসিয়াম, সাইনার্জিস্টিক অ্যাকশন, ক্যালসিয়াম সঙ্গে ডিগক্সিন। এমনিও ডিকক্সিন কাজই করছে বেসিক্যালি সাইটোসোলিক ক্যালসিয়াম কালচার বাড়িয়ে। কুইনিডিন অ্যাড্রেনার্জিক ড্রাগ, অ্যাড্রেনার্জিক ড্রাগ কী করতে পারে? অ্যারিথমিয়া করতে পারে। Uses. What are the uses of digoxin? Sorry? হার্ট ফেলিওর, এটা একটা। বল ইউজেস অফ তোর ডিগক্সিন, একটা হার্ট ফেলিওর হলো, আর একটা কী আছে? হ্যাঁ, কোন অ্যারিথমিয়া? কোন অ্যারিথমিয়া? একটা হার্ট ফেলিওর ইউজ করা হয়, আর একটা to decrease the ventricular rate in atrial flutter and atrial fibrillation. These are the two main use of digoxin. They may also be used, not used, they may also be used in paroxysmal supraventricular tachycardia. But the main use are two. Heart failure, কোন হার্ট ফেলিওরটা? What do we mean by heart failure? বল, হার্ট ফেলিওর মানে কি বুঝি আমরা? হ্যাঁ, হার্ট ফেলিওর মানে cardiac output is not enough to maintain the existing tissue perfusion demand. এই তো, এটা কম্পেনসেটেড হতে পারে, ডিকম্পেনসেটেড হতে পারে। আর কি হয়? সিস্টোলিক হয়, ডায়াস্টোলিক হয়, তাই তো হয় হার্ট ফেলিওর। ডিগক্সিন কোথায় ইউজ করি আমরা? কোন হার্ট ফেলিওরে? It has got no role in diastolic heart failure. It has got role in only low output heart failure or systolic heart failure. জানতে হবে। হ্যাঁ, now so the usage of digoxin is in heart failure and in the control of ventricular rate. It does not reverse the arrhythmia. Atrial flutter or fibrillation ke reverse korche na, that is only used to control the heart rate. But nowadays other drugs are being used, particularly beta blocker is used, non-dihydropyridine calcium channel blocker, verapamil, diltiazem, they are used to control the ventricular rate. When additional heart rate control is required, there comes the digoxin role. Digoxin can be used in atrial flutter or fibrillation irrespective of heart failure is present or not, but they are more better when there is coexisting heart failure. Right? They are basically inotropic agents. Okay? They increase the myocardial contractility. Dopamine acts on the beta receptor, and dopamine has got action on even in dopamine receptor, D1 receptor. So they are increasing the contractility of the heart. Next ball কি নাম আছে? আর বসিয়া তুই বল, আর কি নাম আছে? হার্ট ফেলিওরে কি ইউজ করি আমরা? একটা আইনোট্রপিক এজেন্ট হলো। নেক্সট বল, বসিয়া। Phosphodiesterase 3 inhibitor, example বল। Inamrinone, milrinone, how does they act? Next one, how does inamrinone, milrinone act? Mechanism of action of inamrinone, milrinone. What does phosphodiesterase enzyme do? Next ball, পিছনে। phosphodiesterase এনজাইমটা কি করে? সাইক্লিক নিউক্লিওটাইডকে ব্রেকডাউন করে। phosphodiesterase 3 এনজাইমে কি ওয়ার্ক আছে? এটা সাইক্লিক ইএমপি এনজাইমকে ব্রেকডাউনকে সাইক্লিক ইএমপি কনসেন্ট্রেশন বাড়িয়ে দিচ্ছে, যার কারণে ক্যালসিয়াম কনসেন্ট্রেশনটা বাড়ছে আর আইনোট্রপিক অ্যাক্টিভিটিটা বাড়ছে। ঠিক আছে, রাইট? হ্যাঁ, তোমার সাইড এফেক্টটা কি আছে? থ্রম্বোসাইটোপেনিয়া। আচ্ছা, একটা তো হলো আইনোট্রপিক এজেন্ট, এক এক করে আসছি। আইনোট্রপিক এজেন্ট, তার মধ্যে রয়েছে কার্ডিয়াক গ্লাইকোসাইড পড়লাম, ডোভিটামিন ডোপামিন পড়লাম, অ্যান্ড ফসফোডাইএস্টারেজ 3 ইনহিবিটার্স, দ্যাট ইজ ইনঅ্যামলিনন মিলরিনন পড়েছি। আর একটা হচ্ছে লিভোসিমেন্ডান। আচ্ছা, নেক্সট বল, আইনোট্রপিক এজেন্ট ছাড়া বল আর কি কি ড্রাগ আছে হাতে আমাদের ইন হার্ট ফেলিওর পেশেন্ট? হ্যাঁ, ডায়ুরেটিক, ভেরি গুড। ডায়ুরেটিক মধ্যে কোন ডায়ুরেটিকটা বেশি প্রিফার করা হয় ইন হার্ট ফেলিওর পেশেন্ট? থায়াজাইড প্রিফার করা হয়। নেক্সট বল, বসিয়া। এসি ইনু ডায়ুরেটিক মধ্যে পড়ে? কোন ডায়ুরেটিকটা প্রিফার করি আমরা ইন হার্ট ফেলিওর পেশেন্ট? হ্যাঁ, নট থায়াজাইড, ইজ দ্য হাই সিলিং ডায়ুরেটিক। ঠিক আছে, হাই সিলিং ডায়ুরেটিক আর মোর প্রিফার্ড, দে আর ড্রাগ অফ চয়েস in heart failure patient. Next ball, examples of high ceiling diuretic. Example of high ceiling diuretic ball. এই এগুলো জানতে হবে রে, নামটা কি জানতে হবে রে। হ্যাঁ, পরীক্ষা কি কি লিখবি? আমি আসি, তোকে জিজ্ঞাসা করেছি বল, তোকে জিজ্ঞাসা করলাম, আমি আসছি নাকি করে। হ্যাঁ, ফিউরোসামাইড, ঠিক আছে, ভেরি কমনলি ইউজড। বসি। আর কি ডায়ুরেটিক আছে যেটা হার্ট ইউজ করি? থায়াজাইড ডায়ুরেটিক হলো, আর হ্যাঁ, স্পাইরালোঅ্যাক্টন ইজ এ অ্যালডোস্টেরন রিসেপ্টর অ্যান্টাগনিস্ট, তাই তো? আর কিছু নেক্সট বল। হ্যাঁ, আর কি আছে? আর মেটোলাইজন, হ্যাঁ বলছি, কারণ কেন বললাম নামটা বলছি আমি। ফিউরোসামাইড, বসিয়া, ফিউরোসামাইড is a high ceiling diuretic, that is the drug of choice in heart failure patient. It immediately relieves the congestive symptoms. Now the problem is that continued use of this diuretic causes resistance, drug resistance. Now when drug resistance occurs, metolazone or the aldosterone receptor antagonist can be added to decrease the resistance of the furosemide drug. There comes a role there. Right? Now, the patient having decompensated heart failure is started on the high ceiling diuretic, and when the patient improves, the congestive symptom decreases, the patient is maintained on the maintenance dose of high ceiling diuretic or the thiazide diuretics, whatever it may be. What are the other drugs? বল। হ্যাঁ, ভ্যাসোডাইলেটর। কি কি ভ্যাসোডাইলেটর হাতে আছে হার্ট ফেলিয়ার পেশেন্টে? হাইড্রোলাইজিন আছে, আর অর্গানিক নাইট্রেট আছে, আর এসি ইনহিবিটর, এআরবি তো এর মধ্যে পড়ে না, ভ্যাসোডাইলেটর বললাম না। আর কি আছে? ভ্যাসোডাইলেট করে, আমি বলছি না। আর রয়েছে তোর সোডিয়াম নাইট্রোক্সাইড, ঠিক আছে বস। হোয়াট আর দ্য অর্গানিক নাইট্রেটস অ্যাভেলেবল? নেক্সট, হোয়াট আর দ্য অর্গানিক নাইট্রেটস অ্যাভেলেবল to treat heart failure patient? Next we ball, boss here. Sodium nitrate is not nitrate, it's not nitrate. Isosorbide trinitrate, isosorbide mononitrate, glycerol trinitrate, these are the drugs. Organic nitrate available. ঠিক আছে? আচ্ছা, so basically the organic nitrate, they are vasodilators. They decrease the preload on the heart, and the arterial dilator, that is hydralazine, is decreases the afterload, because they are more more causing arterial vasodilatation. And the sodium nitroprusside, they have got both veno and arterial dilatation action. Now, the patient who present with decompensated heart failure, initially the glycerol trinitrate we give in a intravenous dose, intravenous glee. And then when the patient improves, the organic nitrate can be given as and when required or may be maintained on the long acting nitrate. Now, they does not decrease the mortality. The organic nitrate or the diuretics, they are not increasing the mortality, but they are decreasing the symptoms. Now, what are the drugs available which decreases the mortality in heart failure patient? বল পিছনে একটা ডায়োরেটিক্স হলো, একটা রয়েছে তোর এটা আইনোট্রপিক ড্রাগস, বাট নান অফ দেম ডিক্রিজেস দ্য মর্টালিটি ইন হার্ট ফেলিওর পেশেন্ট। একটা হার্ট ফেলিওর পেশেন্ট আসলে পেশেন্টকে সিমটম ফ্রি করতে হবে, আর পেশেন্ট যেন প্রাণ না হারায়, লাইফটা প্রলং করতে হবে। তার জন্য যে ড্রাগগুলো মর্টালিটি বেনিফিট করে সেটাও দিয়ে রাখতে হবে। হোয়াট আর দ্য ড্রাগস উইচ ডিক্রিজেস দ্য মর্টালিটি ইন হার্ট ফেলিওর পেশেন্ট? নেক্সট বল। বসে তারপরে হ্যাঁ জোরে বল। হ্যাঁ না, nitroglycerin is not used in heart failure patient. No, obsolete. There comes very important drug ACE inhibitor ARB. ঠিক আছে, তারপরে কি আছে বিটা ব্লকার হাতে হাতে, আর কি আছে অ্যালডোস্টেরন রিসেপ্টর অ্যান্টাগনিস্ট। These are the drugs which decreases the mortality and has to be given. ঠিক আছে, আচ্ছা এটা মর্টালিটি কিভাবে ডিক্রিজ করছে তার জন্য প্যাথোফিজিওলজি অফ হার্ট ফেলিওর জানতে হবে। What happens when the heart starts to fail? Then the compensatory mechanism start in the body to increase to help the failing heart. So what are the compensatory mechanism in heart failure patient? Next ball. বসিয়া কি হার্ট ফেলিওর পেশেন্ট যখন ডেভেলপ করে তখন কিছু কিছু কম্পেনসেটরি মেকানিজম সাইড বাই সাইড অ্যাকার হয় যাতে হার্টের পাম্পিং অ্যাকশনটা বাড়ানো যায়, to relieve the symptoms. Next one. বলতে পারবি রে? বল তুই বল, বলতে পারবি? বলতে পারবি? জোরে বল। Compensatory mechanisms in heart failure patient. হ্যাঁ, একটা তো feeling pressure in the heart is increased. So what happens? The Frank-Starling law. Due to the feeling pressure of the heart being increased, the myocardial fiber increases, that causes increase in contractility. এটা একটা মেকানিজম রয়েছে। সেকেন্ড মেকানিজম কি? র্যাশ অ্যাক্টিভেশন। আর কি আছে? aldosterone is increased in the body, তাই তো? So problem রয়েছে with the RAS activation, and because of increased aldosterone in the body, the the cardiac remodeling occurs, cardiac apoptosis, fibrosis, and that is adding to the mortality in the heart failure. And these ACE inhibitors, angiotensin receptor antagonists, they decrease the mortality by decreasing the cardiac remodeling. ঠিক আছে, তো Basically, what are the beta blockers? Those are preferred in heart failure patient. No, any beta blocker can be used. Primary problem is that the non-selective beta blocker, and here we prefer cardioselective beta blocker. Carvedilol is non-selective, but definitely we prefer in heart failure patient because that is additionally decreasing the mortality. R ki ache? 4 drugs are there. Is carvedilol, number 1, nebivolol, bisoprolol, and sustained release metoprolol. These are the drugs preferred, beta blockers preferred in the heart failure patient. আচ্ছা, এটা গেল তোমার র্যাশ ইনহিবিটার্স হলো স্যাকুবিট্রিল। স্যাকুবিট্রিল কি করে? জানতে হবে। স্যাকুবিট্রিল ভ্যালসারটন খুব কমনলি ইউজ করা হয় ইন হার্ট ফেলিওর পেশেন্ট উইথ রিডিউসড ইজেকশন ফ্র্যাকশন। Sacubitril is a neprilysin inhibitor. আচ্ছা, এটা তোমাদের হার্ট ফেলিওর উপরে রয়েছে। কিছু জিজ্ঞাসা করার আছে বলো? ঠিক আছে, পেমেন্ট করে দিই। হ্যাঁ।